Hello, good afternoon. If everybody could take their seats, we're going to get on started so we can stay on time. And for those of you that were around yesterday, you know what a great day this has been because so far we've kept on time for everything. So let's continue that trend. My name is Heidi Dalton. I am a pediatric intensivist that does ECMO in anybody from A to Z and from babies on up. And I work at least part-time at Inova Fairfax Hospital in Virginia. This is my partner.
Bishoy Zachary. I'm an intensivist and medical director of ECMO at OHSU, adults, and chair of education for ALSO as well.
And we're just going to tag team here, but we're going to get started with our first speaker of the afternoon, who's going to talk to us about chest tubes and management of the pleural space. And I hope one of the things that she's going to say is just don't say no. But anyway, Natalie Roy from Boston is here.
She's right here.
And she's right behind me. And so Natalie, go ahead and kick us off. And this is the advancer. This is the pointer.
Thank you so much. I'd like to thank the organizers for the opportunity to present here. I'm a congenital heart surgeon. I'm also an ECMO surgeon and as well as a critical care physician. And prior to being at Boston Children's Hospital, I was at Mass General where I practiced adult ECMO and saw the inception of the program there. So I have no disclosures. In the last 5 years, there's been really a dramatic increase in the use of ECMO for adult patients thanks to the pandemic. With that, there's been also a significant increase in the publications to help us guide our management and our practice. However, related to chest tube placement, there's really only a few case reports, observational studies, or single center and retrospective studies of a few retrospective studies related to anticoagulation to help us. And so I'd like to go through those and discuss this controversial topic. I'll start with a case. This is a patient on VA ECMO, as you can see. This was a teenager who presented with heart failure and ended up having an ECPR event. And following the placement of or an attempted placement of a line, he developed a large pneumothorax. And so at that point, the venous pressures, the venous return was less. We were not able to sustain high flows on ECMO to support him. And so do you put a tube in, PTT is over 150 in this patient. Well, obviously we didn't really hesitate, and we placed the tube, and this was a successful story in terms of management for the chest tube, where there was no complications. The patient long recovered, and the patient was weaned with aggressive heart failure management. However, the outcome wasn't necessarily positive one in the end for other reasons, but. Conversely to that, this was another patient that I lost a lot of sleep over early in my practice. It was a 28-year-old male with ARDS of unknown etiology. He was actually a resident and ended up on VV ECMO, and he wasn't recovering. He had a biopsy, and his chest tube had clogged and suddenly developed a right large pneumothorax, for which he received a drain, and that was complicated by hemorrhage with multiple thoracotomies, multiple transfusions, and one has to wonder whether or not this led to worse transplant outcome in this patient. So this just explains really the breadth of the problem in these complex patients on ECMO, and especially after a long time on ECMO. So. Related to ARDS, pneumothorax is a known complication, and it's associated with worse prognosis, present sometimes late, and can sometimes be managed conservatively. The question is who can be managed conservatively and who can't be. There's obviously a very paucity of data published in terms of patients who are supported on ECMO. And adding the layer of complexity associated with COVID, certainly, if you place a tube, you can generate aerosols if there's a significant leak. And also these patients in whom you would normally stop anticoagulation for management of their thoracic cavity, well, they have a significant increase in thrombotic complications. And so what do you do about these patients? So we'll go through the few studies that have been published, and perhaps we can come to some conclusions. Obviously, this is just an observational study, but I wanted to put it out there. It's a study looking at 71 patients who had complications related to either pneumothorax or pneumomediastinum in the setting of COVID in the UK with variable onsets. And of those, only half of them required to have drains placed on ECMO. The majority of the other patients had their pneumo developed in the setting of either pre-presentation or later at different points during their admission. So when do you need to put a patient with who has a pneumothorax develop while they're on ECMO? Well, obviously, when your venous flow is compromised and you have lower flow that's not going to support your patient, then that's an obvious indication. But there's a lot of in-betweens. This is a study where it's a single center study looking at a unit where they closed unit for ECMO due to COVID. And I think the interesting thing about this study was that they looked at they explained their rationale for management, basically. They had a very high proportion of their ECMO patients, despite low tidal volumes, that developed pneumothoraces with a high mortality. You can't really see from this picture, but all the X's are the pneumothoraces. And if I understood this graph appropriately, they had over 75% mortality in these patients. I want to shift gears a little bit because I think that ECMO has actually had really good successes for management of pneumothoraces. Patients who have bronchopleural fistulas if you're able to manage them with ultra protective ventilation with low PEEP and low driving pressures, have a high incidence of success in management of their bronchopleural fistulas. This is a case report of 4 patients who were successfully managed with ECMO with a complete resolution of their BPFs, were able to decannulate. There was also a review of the literature in the same article looking at an additional 14 cases for trauma to transplant and to post-surgical management of BPFs with very good success rates. And again, another one for COVID, basically, where managing the patient on ECMO with ultra-low or ultra-protective ventilation led to successful management of the fistula. Obviously, when talking about performing chest tubes in patients on ECMO, one has to balance bleeding and thrombosis. And so I just wanted to review a few of the papers that looked at bleeding on ECMO. This is a series, single-center series from Germany looking at patients on VV ECMO where there was a significant hemorrhage in patients, in one in 5 patient, basically. The majority of those, or thoracic bleeding was prevalent in 40% of those patients. And these complications happen either spontaneously or after interventions, as well as postoperatively, required a large amount of reoperation, procedures or reoperation. And those patients had higher mortality and length of stay. Additionally, a review of the ELSO registry looking at bleeding and thrombotic complications in adult patients supported on ECMO showed that 40% of the patients have either bleeding or thrombosis. In this series, the thrombotic events were more frequent. However, the bleeding events were more significantly associated with mortality. In addition, these patients, you can see here the red represents the bleeding and the blue the thrombosis, but obviously everything to the right is associated with increased mortality. Bleeding and especially pulmonary bleeding as well as intracranial bleeding, those are all like adverse outcomes of patients on ECMO. I wanted to show this just to show that at the bottom totally of the slide, if you look at, I don't know that I can show properly, but here, if you look at the time on ECMO and obviously the longer the patients are on ECMO, the longer there's risk for bleeding. Looking at the COVID patients, the majority of those patients had complications, either bleeding or thrombosis. And again, just to express that these patients had obviously increase in thrombotic complications related to their circuit. And in thinking of performing procedures on ECMO for those patients, there's definitely a higher risk of thrombosis if you stop the anticoagulation. And that the patients who end up with bleeding complications end up with increased mortality. And so now that I've confused everyone, do you put a tube in? I think that it is not unreasonable to consider if a conservative approach can be appropriate if it's a small pneumothorax, as long as one can monitor the progression and consider the hemodynamics and the ability to support on ECMO. Using certainly ultra-protective ventilation on ECMO can minimize the risk for progression of these pneumothoraces. And I think that as these patients have disease progression later in their course where they end up with a lot of loculations, it's important to use imaging and not necessarily jump the gun on draining a patient who has had ARDS that's progressed for weeks. However, I think it is safe to do procedures on ECMO. I think it's important and if feasible to hold the anticoagulation. It's important to have an experienced provider do the procedures, and please use image guidance to proceed to drainage of these pneumothoraces, as there can be adhesions and bullae. Not everyone is stable enough to go for a CT, but you can have very good visualization with a point-of-care lung ultrasound. If possible, using a percutaneous approach rather than surgical. And I think that the last thing I'd like to stress with is that ECMO anticoagulation protocol in your institution should be based on the clinical status. That means whether or not the patient is bleeding or not, as well as a functional assay, and if possible, to supplement that with point-of-care testing, such as the use of TEG to sort of optimally manage your patient and limit your complications. So with that, I'd like to thank the organizers for inviting me.
Thank you very much. And we'll do questions at the end of the session, if it's okay. I'd like to invite our next speaker, Philippe Lemaitre from New York, talking about tracheostomy.
Well, good afternoon, everybody. I would like to thank the organizing committee and Kara for giving me the opportunity to have this talk. I have obviously no specific conflict of interest pertaining to the discussion here. I would like first to apologize to everyone in the room for my terrible French accent. I hope that you'll all understand what I mean in these slides, and most of it is written here. So, considering a patient who needs a trach being on ECMO comes with two feelings. The first one is good news, the patient's on ECMO, so ventilation and airway management is not going to be that much of a problem. Great, but bad news, patients on ECMO, so there's an increased risk of bleeding, there's possible circuit issues that may be looming because of the need for holding the anticoagulation, and also the patient's already in enough of trouble that we cannot afford any complication of the tracheostomy procedure. So this being said, why are we needing to do the tracheostomy in the said patient? Well, the patient is most likely expected to have long-term need for ventilation. Clearly, the tracheostomy is not going to improve the respiratory mechanics a lot because it's already terrible. Possibly, it's going to allow less sedation, but not in all patients. We have all experienced that. It's going to improve oral care and airway management. So what are the risks when we do the tracheostomy? Risks is predominantly bleeding. In the general trach population, around 5%. In the ECMO population, major bleeding, 1.5 to 8. Minor, that can be self-limited, 30 to 40%. That's what is reported. The bleeding may be related to the type of cannulation. If there's a big avalon cannula in the neck and increased venous pressure, might be worse in an ECMO patient. Then we face the possible risks of losing the airway just during the procedure right afterwards. Good news, you're an ECMO, so that's not too much of a problem. And then finally, the one that really needs to be avoided is a direct membranous wall or esophageal injury that we absolutely need to avoid. So to improve the safety for a patient on ECMO, the recommendations are that anticoagulation needs to be, that there might be we want to delay, the tracheostomy down to 6 days after the cannulation to allow time for the inflammatory response of the initial lung injury to wear off on the one hand, and second, to extend the periods of anticoagulation up to 6 hours before and after the tracheostomy. It's been shown that there is not much increased risk for circuit clots if the anticoagulation is held for that long. And in our experience, we've sometimes hold that for longer than just those 6 hours. You can check for coagulation before doing the tracheostomy, acknowledging that the lab is always going to be delayed to the moment you have to do the procedure. So if there is still bleeding at the time of doing the tracheostomy, there's something that still needs to be corrected, no matter what the lab has said 2 hours before the tracheostomy. I like personally to review images that are available, a CT scan, even if it's an old dated CT scan, the anterior jugular vein is always at the same place, even if the CT scan is dating 2 years old. And if there's no imaging available, a great tool is to use bedside ultrasound just to review anatomy before performing the tracheostomy. Trying to mitigate the venous pressure in the PEEP can also be recommended in helping with less pressure on the venous side. But most importantly, and I'll discuss that prior to the timing, actually, an optimal technique is needed to make sure that the patient is going to be faring well and having no issues from the tracheostomy procedure. So I'll describe 3 techniques and predominantly leave it to the appreciation of the person who's doing the tracheostomy. This one being open. The reason why describing open is important is just because it gets back to the landmarks that are critical in performing a safe tracheostomy. You cannot do a safe tracheostomy if anatomical landmarks are not recognized. So want to find where the cricoid bone is, where the sternal notch is, and where the isthmus of the thyroid is. In some patients, palpating this is going to be impossible because they're too big. So you're going to have to find a way to go through safe technique without really palpating these landmarks well. Just quickly, I remove stiff OG or NG tubes in all patients receiving a tracheostomy to avoid any stiff structure in the esophagus. Palpating the landmarks, as I said, is critical. You can do either a vertical or a horizontal incision. I prefer a vertical one because the trachea is always on the midline or most frequently on the midline. Sometimes you have to go a little bit higher, lower, but never too much left or too much right. Dissection straight down, separate the strap muscles. I divide the isthmus when doing an open trach. The incision in the trachea does not really matter. I prefer doing an inverted U, and then the cannula is directly inserted. Safe procedure, but a lot of dissection that can be a problem on a patient on ECMO with all the issues that we discussed already. Percutaneous technique has gained widespread and is now currently the most performed procedure to do a tracheostomy in patients in the ICU. Just briefly under bronch guidance, Seldinger access to the trachea. I prefer using a small needle to localize where to enter the trachea and then use an 18 gauge to place the wire, then dilate over the wire and then place the trach tube over the wire afterwards. The ways to dilate, there are many that are reported. Most of us know well the Ciaglia blue rhino technique. but it was initially performed with serial dilators to have to be placed over the wire in the first place. But nowadays, this is sort of summarized with a single progressively dilated tool, a dilation forceps that could be slid over the guide wire has been described in a Greeks technique that I personally have never used. A BREAKOUT twist, that is some sort of a screw that can be screwed in the trachea, has also been described to dilate. And then finally, Ciaglia also developed a balloon dilation technique with a blue dolphin. No matter what the technique, you're going to have to dilate the trach at some point. So my preference in these patients and in any patient with some anatomical concerns, as we'll see, is to use a hybrid technique. And actually, rather than having to bring the patient to the operating room to do the tracheostomy, which is always a mess, especially at Columbia, I prefer bringing what is needed to do a safe trach at the patient's bedside, and that is a cautery, a headlight, and a trach tray. And with this, with this, using a very small vertical incision, just that we start just underneath the cricoid bone and cautery dissection, you can just gently head midline up to the top of the isthmus that is lifted gently caudally, exposing the area where you're going to have to land the tracheostomy. I place then purse strings so that it's already done, don't need to do that later. And then what is very helpful with this technique is with the headlight that you're going to trans-illuminate both ways. So basically, this is a view from the ET tube where I could see the light of my assistant who's going to perform the tracheostomy, exactly where I need to pull the tube. And then conversely, because she's sitting in the room, she could be seeing the light of the bronchoscope as I was pulling the ET tube. And so we could really meet exactly where we wanted to be without any kind of wondering whether I was too high, too low, where to get access. All of this is very safe, and all of this is performed with thinking about the non-ECMO patient. The patient is ventilated down to very late in the procedure, no need to change anything at that moment. And then the technique sort of is to PERT, but the trachea only at that moment. The advantages of the vent is not really true for the ECMO patients, but all anatomical considerations using this technique are controlled. You don't need, and I think that is really critical, you don't need to push to dilate the trachea. And one of the major issues when we get patients with early tracheoesophageal fistulas, there's nearly always a step where the person who performed the tracheostomy had to push too much, nearly always. Either that, or it's been performed too high or too low, which also comes into a problem of like dilation and anatomical poorly controlled situation. I personally put the incision first. The purse strings are placed then immediately so that you don't have to try to put the purse string underneath the flinge, which is always a mess. And then minimal dissection and good purse strings help minimizing the bleeding complications. And in our experience, we don't see that much more bleeding with this technique compared to patients that are not on ECMO, for speaking about the ECMO population. So in terms of timing, you want to do it early or delayed. Well, there are potential benefits of early tracheostomies that are published, but all of these are demonstrated in the non-ECMO population. And early means what? Means it 4 days, 7 days, 10 days after the intubation, or after cannulation? What is early? When is early? The survival benefits, or most of the benefits, are demonstrated in ARDS. Indeed, it allows to decrease sedation and improved comfort. But in some of our ECMO patients, they still require lots of sedation even after the tracheostomy, just for the sake of tolerating the circuit sometimes. So I'm not sure, basically, that all of the benefits that are seen in a patient who's relying on the vent are still completely true for a patient who's, at that moment, certainly not that much relying on the vent because of ECMO. Are there benefits of delaying? That appeared in the early days of the COVID pandemic, when we used to be afraid of manipulating the airway of the COVID patients because we wanted to keep the healthcare team safe. So in the early COVID, we were delaying a little bit, and then it's been shown by our team and others that actually it is safe for the healthcare team to perform a tracheostomy even reasonably early, after a few days in the COVID patients. Now, What about the timing if you're in a program that aggressively wants to extubate the patient? Then if you hope to extubate the patient, then you possibly don't especially want to do the trach down to the moment you know whether you're going to be able to extubate the patient or not. So I think that a tracheostomy in the ECMO patients will have to be performed in my experience, most cases, but the timing is actually ill-defined in a challenging and heterogeneous population of patients. So again, I just get back to delaying could improve the security and the safety for the team predominantly, and that was experienced in the COVID-19 pandemic early on. Just to remind that appropriate PPE is mandatory because the trach is considered an isolating procedure. There's quite a few people required in the room. We paralyze all the patients to minimize the cough reflex, and apnea is needed in the ECMO patients, not too much of a problem. And again, as I said a second ago, it is safe even if it's performed not after 2 weeks in the COVID population. So in conclusion, I think that performing a trach in an ECMO patient, I prefer using the hybrid technique that I described that I feel is very safe, and I don't see much more bleeding with this technique. But I would leave that, I'm a surgeon, I would leave that to the operator's preference. Who am I to tell another surgeon how to do things? The timing, I believe, has to be adapted for each patient. And then the technique in a tracheostomy is safe. The bleeding complications, if the trach is performed cautiously, are not going to be much worse than for non-ECMO patients. It's safe for the circuit also to hold heparin for prolonged periods of time, and then it's safe for the team to manipulate infected patients, provided the PPEs are appropriately worn for the procedure. And with this, I think I'll take all the questions after the session, and you can contact me up there with pleasure. Thank you.
Thanks, and I loved your accent, actually. Our next speaker is Phil Mason from San Antonio. He's going to talk to us about what to do with RV failure, something that we see especially in VV patients, and when to switch to VA is always an interesting question that Phil's going to answer for us.
No pressure there. I have an hour for this, right, Heidi? Just to make sure I got it right. Okay, hey, welcome. Thanks, guys. I'm Phil Mason. I'm from San Antonio, Texas. And yeah, we're going to talk about specifically patients on ECMO with ARDS and when to convert to some sort of mechanical support, whether that's veno-arterial configuration or, especially in the last couple of years, a veno-PA, VPA, or RAPA configuration. Now, let's start with the end in mind. I'm going to skip to the end. I'm going to disappoint you. I have no idea when you should convert to these configurations. I just don't. I have a few options for you. I have one example of when you shouldn't convert, and I have some ideas on how you may develop a vigilant approach to identifying it. But unfortunately, we don't have great answers. I have a ton of financial conflicts, but none of them relate to this talk, so I can skip that slide. Just a little bit, first of all, about the scope of the problem. Now, you're all smart academics, and you know when you try to define the incidence of something, it depends on the exact population and how hard are you looking for it and how do you define it exactly. But across the board, I think it's clear that RV failure, by some definition, is very common in ARDS. Maybe a quarter, maybe up to a half of the patients. So the burden of the problem is really significant. And there was a lot of talk about this even before COVID. We started hearing a lot of talk about RV-friendly or RV-protective ventilation. It turns out it looks a whole lot like lung-protective ventilation. But COVID really kind of, I think, maybe exacerbated this problem or brought it more to the forefront. A number of studies looked at the prevalence in COVID, and this one found RV dilatation in 41% and RV dysfunction, by their definition, in just over a quarter. So again, very common problem to deal with. So let's talk about how we should support these patients mechanically. Now, the talk is supposed to be, when should you convert? But I first want to stop off one step shy of that and talk about this paper that you've all seen by now. This is out of Chicago in the COVID population. And they reported on 40 patients that they never had to talk about converting because they went directly to mechanical RV support right out of the gate. It sounds very aggressive. This technique comes with some cost. It comes with some risk. And it's just more difficult than standard VV ECMO cannulation. However, you cannot argue that the results are quite impressive. Now, we haven't seen them replicated yet, and there's probably a lot more to the success of this group than just their cannulation strategy. But the asterisk, by the way, means that the report of 82% survival was in a subsequent paper, not this one. But they did follow up and have very impressive results with this preemptive RV support configuration. Wasn't completely off the wall, though. They did, as you know, placing a PA cannula, the first step is placing a pulmonary artery catheter, and they did report in a subsequent publication that significant pulmonary hypertension was present in 100%. So it's a sick population. So a very aggressive approach, support all the patients right from the start, labor intensive, a little more expensive, but perhaps has really good results. The next level of nuance might be to look for a subset of patients where we can go directly to mechanical support using some different parameters. So some patients go on VV, others just skip that step and go right to mechanical support. We don't have a lot to go on here in ARDS, so I'm going to shift over to a bridge to transplant population just briefly. This paper is by a group, transplant group from San Francisco, describing their experience with ECMO as a bridge to lung transplantation. 76 patients, 68% transplanted. That's good, by the way. And their outcomes were nice at 1 year survival. And they took the approach that if you were bridging to transplant and you had any degree of RV dysfunction on echo or a PA systolic pressure of greater than 50, you never went on VV ECMO. You went directly, in their case, it was to VA ECMO. If this was done today, it may also be a VPA configuration. A number of other groups have described this. In particular, the group from Columbia has written up several times their case series of lung transplantation. Their most recent case series I saw from there was 2019, and roughly half of their bridge to lung transplant patients, and these are not heart lung transplants, these are lung transplants, roughly half of them were supported with VA ECMO from the very start. Just based on their experience of, hey, this patient looks great for VV ECMO, let's put them on VV ECMO, and then a week later, they're in trouble and having to convert. So this is kind of a middle ground approach, not putting it in all the patients, but maybe identifying them preemptively. Again, I don't have anything like this for ARDS specifically, but perhaps the same approach could be taken there. Now, I'll start by reminding you that VV ECMO does not provide right heart support, but it does provide some right heart benefit. You've all seen this before. But the situation we normally or often find ourselves in is we're on this support already. We're on optimal, maximized medical support, which frankly is very ineffective and disappointing in this type of pulmonary hypertension, but we're on it, whatever that may be. And then we're left to figure out which patients we need to upgrade that level of support in. And I'm going to start, because I'm going to be a good example of what not to do. Let me tell you, this is not when you want to convert. So this is when you come in the morning and the nurses say, hey, we went to suction the patient last night and they were doing fine, but then they started coughing, had a big coughing spell. And ever since then, the blood pressure's been down. Does this sound familiar? Does this sound like a pulmonary hypertension patient to you? Yeah. So they're on pressors. The MAP is low. The creatinine's already starting to go up. Multi-system failure. Then, 3 days too late, you decide to put an echo probe on their chest. And oh my God, the right ventricle is the size of a football, an American football. I know we got a lot of people here. It's the size of an American football. The TAPSI's 1.2. There's wide open tricuspid regurgitation. And you say, oh, look, they have right ventricular failure. Now you're trying to rescue this patient. Hence the life preserver. That life preserver is going to look a whole lot like an emergent, middle of the night, femoral VA ECMO cannulation. It's a great way to be rescued, I suppose, but not the situation we want to be in. So we'd like to be a little more proactive, and I'm going to propose a few markers that you might use to develop this approach. Clinical markers are the easiest. They're readily apparent when you look at the monitor. Unfortunately, tachycardia is just ever present in the ICU and is entirely nonspecific. Hypotension is also nonspecific and unfortunately quite a late finding. If you have a PA catheter, it can be very valuable. I think most of us don't use them as often, particularly in non-cardiac patients as we used to. And remember, some of the values are hopelessly confounded by veno-venous ECMO. Most importantly, the PA saturation, right? You can't interpret that. But you could use the PA pressure, you could use the pulmonary artery pulsatility index, other things. But what you should be using is CVP. Now, y'all remember this study? Have y'all seen this study right here, the Tale of Seven Mares? Nobody measures CVP anymore because we're not nuanced people. And we used to measure CVP for volume responsiveness, and we finally learned the lesson that it doesn't work. But we couldn't just exclude it from that part of our practice. No, we had to throw it out the window completely. So none of my patients have a CVP now. They all have a stroke volume variation, which of course is confounded in RV failure. So I have to remind the team, I want a CVP in all of my sick ECMO patients. And that's my first marker that I'd like to follow. Laboratory markers, BNP or NT-proBNP, this is usually institution specific, but largely interchangeable with different normal ranges, of course. Kind of came to attention and is quite useful in differentiating cardiogenic from non-cardiogenic pulmonary edema, but also in a number of conditions, pulmonary embolus, interstitial lung disease. It reflects pulmonary hemodynamics. It correlates with outcome. Your lab can measure it with a reasonable turnaround time, and it's very easy to trend. So this is another important part of the monitoring pathway in my hospital. Unfortunately, I have no idea what the cutoff is. The cutoff is it's higher today than it was yesterday, and yesterday was higher than the day before, or something like that. So I don't have a perfect approach, but this is part of it for sure. Remember that it's confounded. A hypertrophied ventricle can produce more than a non-hypertrophied ventricle, and it's cleared by the kidneys. So renal failure impacts this, but you can still use a trend number. And probably the most useful thing we have here is echocardiography. Many of you are skilled enough to make this diagnosis at the bedside, any time of day, 24/7. And so we have become very aggressive at using echocardiography for this in our program. TAPSE is what you're most familiar with for most people. Anything under about 1.7 or 1.6 centimeters indicates RV dysfunction. There was a study in COVID, by the way, that said this value was relatively preserved in that patient population. But TAPSE, there's another measurement called S prime that you can achieve. I won't go into the details of that. Fractional area change, which is a 2D correlate of cardiac output or of stroke volume, really. Basically, you just trace the chamber in diastole. You trace the chamber in systole, and the percentage change is what you're looking for. And 35% is a good cutoff. Also, just the degree of dilatation and the degree of tricuspid regurg. This can be a formal echo, and a lot of hospitals it will be. This can be you just going to the bedside and doing a point-of-care echo. So this is readily available to you. Now, I don't know if this pathway works. So if you want to take a picture of it and zoom in on it and use it in your hospital, go ahead. Some of my colleagues, I think some of them are here today, are going to report our results with this. We got burned a lot of times, guys. I came in the middle of the night and converted a lot of patients to VA ECMO, especially during COVID, that case I showed you. And so we decided to systematize this approach and get a little smarter about it. And this is what we came up with. It incorporates those values that I pointed out before. The only thing that's really quantitative here is the echo findings. And you can see for a degree of moderate dysfunction, we offer 48 hours of medical optimization. For severe dysfunction, we skip that and go right to mechanical support. So this is something we've proposed. Again, we haven't studied this in detail. We're working on doing that now. But something like this is probably a reasonable solution. So I'll wrap up by telling you what I told you on the first slide. I have no idea when you should convert to VA ECMO. I do know that it would make sense in certain patients with RV dysfunction present at the outset of ECMO to just go straight to some sort of mechanical support. Today, that's probably a PA cannula. Just a couple years ago, it was probably a veno-arterial configuration. But that's really, I think right now, center-dependent in what you're comfortable with. But that patient population is out there. In the rest of them, develop some systematic, vigilant approach to identify those patients, convert them on a semi-elective basis before they crash. And for me, that system involves a combination of CVP, BNP or NT-proBNP, if that's what you have, and then daily bedside echoes for us and a weekly formal echocardiogram. Thanks.
Great talk. Thank you, Phil. I'd like to introduce our last speaker, Dr. Mike McMullen from Seattle Children's. Going to talk about cannulation complications and surgical mishaps. Should be good.
Thanks, Bishoy. I'd first like to thank the committee for inviting me, and I'd like to thank Heidi Dalton, who's always been such a great mentor and most importantly, friend. So thank you so much for that. I have no disclosures. I'm a surgeon, so they're going to all be pictures. When I was in university many years ago, when I was much younger and a little more foolish, I decided to join the college skydiving team. And it was great. The first day we went out and we learned how to pack chutes, we learned how to jump off logs, and then about 3 hours later they took us up in an airplane and threw us out. And I remember I jumped out and I looked up and I saw this, which is important because they told us that if we don't see this, you're in trouble. And I learned really two very important things that day. One is that I will never skydive again in my life. It was horrible. And the second is that by following the same principles we learned during that, I can apply that to other high-risk activities in my life, including cardiac surgery and ECMO. And those principles are preparation, proper execution, and most importantly, confirmation. And that's really the theme I'd like to talk about today. This doesn't just apply to the surgeons, it applies to everybody. So when we look at ECMO patients, there's various different types of support, and each of these supports provides certain benefits and potential risks. And I'm really not going to talk so much about central cannulation, but a little bit about peripheral cannulation or cervical, because I'm a pediatric cardiac surgeon. It's really important to understand the anatomy, and if we don't understand the anatomy, we have no idea what we're doing. And so in our hospital, we have this little diagram, and we know when a patient comes in and they've had some imaging, we know what vessels are available. Now, this is critically important because the surgeon, the proceduralist, wasting a lot of time trying to gain access to a vessel that has no patency is going to lead to major problems. And so I can't stress importance enough of knowing what the unique anatomy of your patient is based on previous procedures or unique anatomic features. Similarly, once you know where you're going to go, you have to understand what those vessels look like. And I really strongly advocate using ultrasound. Ultrasound's fantastic. It'll tell you whether the vessel's patent. It'll tell you the spatial relationships between the vessels. And at least in the pediatric population, and I think in some adult populations, it'll tell you the size of the cannula that you can get in. And I think that, in our center anyway, we always do ultrasound, at least when we have time, to try to really understand what we're getting into. And it's also really important for confirmation of placement as well. The wrong button. So this is an X-ray, and this is kind of like a group therapy session. I get to go and tell you all my faults and my sins. So we're going to go through a few of these. So this is a small child who's on VA ECMO through the neck, and just looking at this X-ray, you can see that arterial cannula is in way too far, and so that leads to a lot of consternation among the staff. So the question is, where is that cannula and what's going on? And if I went around the room, I'd probably get about 5 or 6 different answers. And it's true, there's about 5 or 6 different places this could be, and none of them are in the right place. So you really have to understand the local regional anatomy. So in the chest, it's really complicated. You do something through the neck, but all the action is down inside the thorax. And so if you look at this, you realize that if that cannula is in too far, it could be in the ventricle, the left ventricle. It could be in the descending thoracic aorta. It could be in the pericardial space. It could also be in the pulmonary artery, right? And you don't know because you're just looking at this funny X-ray. Now, it turns out in that patient, we get an echo, and this is, I guess, the second important point. When in question, get an echo. If you're anywhere near the heart and you have any question at all, you have to get an echo to figure out what's going on if you're not absolutely sure. So we get an echo on this kid, and for those of you that don't read many echoes, the one on the right is the cannula, and then you can see it's kind of banging up against the aortic valve, or at least it looks like it. And when you turn on color flow, you see that thank God there's no aortic insufficiency, because if there was, that would mean that the cannula went right through the aortic valve and avulsed it, which of course is a surgical emergency. So based on concern of the post-op imaging, the X-ray, we got an echo, and based on the echo, we can pull back and we know that we're safe, we can get in the right location. But without a high index of suspicion there's a problem, this patient would have stayed like this and probably would have had pulmonary hemorrhage and died. So dual lumen cannulas, they're fantastic. Boy, I mean, I'm old enough now to remember the really crappy ones before that would always deform and shift, and now we have these really fantastic cannulas. And they enable us to do some amazing things, but they do have their own challenges. And so this is one of those that are available, and you can see this is a great location of this cannula. You'll probably never actually see this in your practice. You can see the tip in the IVC drawing the blood. You can see the actual port that goes right toward the trachea. It's a perfect image. You'll never see this again. Now, that cannula, all the activity is down in the chest, right? But the complications can occur up in the neck. And it's important to realize that the cervical space is full of some really important structures: carotid artery, pulmonary vein. If someone's going on VV ECMO, there's a really high likelihood they're going to have high central venous pressure. So all those veins are going to be engorged, and so it's a very risky space. And if you get in there the wrong way and you get into some bleeding, you end up with this giant hematoma like this. which turns what could be a very straightforward cannulation into a total disaster. So again, careful preparation, understanding what you're trying to do is really important. Now this is a patient. I was asked by one of our general surgery colleagues to assist. It was I think it was a pretty young kid who was going on VV ECMO for respiratory failure, and the cannulation was taking way too long, and the patient was becoming sicker and sicker. And they got to the point where they couldn't actually advance the cannula very well. They were stuck. They couldn't understand why. And the saturation started to go down, and then the worst possible complication almost occurred. He almost had cardiac arrest. So it was almost going to go from an urgent VV to VA cannulation. And so I said, well, let me take a look. And so I fumbled around. I managed to get the cannula in. We went on ECMO. And everything looked pretty good until we looked at this cannula, and I noticed this flash in the venous limb. I thought, that's kind of curious. So we got an echo, and we look around, and about 30 minutes later, we realized that what I had done is I'd shoved the venous cannula through the back wall of the jugular vein into the carotid artery, and this patient was on, maybe the first time ever, AA ECMO. But you know what? The saturation was fantastic. You can imagine, no one liked this. So, we had to take this kid to the OR, and this is what's left. You have to basically open this kid, all the way around the neck, into the chest, and totally reconstruct that area. Now, what happened here? What happened is I didn't have preparation because I just walked into this disaster. I didn't execute it properly because I was under pressure, but I salvaged it only because I went back and I looked for confirmation and made sure there wasn't a problem, or there was a problem that could be addressed. So again, very important. This is that picture again, and this is the ideal state. But that ideal state doesn't tell you much, right? They all look good on X-ray depending on the orientation. They go, you really need echo for these patients. And so this is what you're looking for. You're looking for, again, this is the ideal echo. You're looking for that little hole there, and that's right across from the tricuspid valve, and you turn on the Doppler, and you can see this beautiful cone of flow right across the tricuspid valve. If you see that, you're golden. That patient can stay on ECMO forever and do perfectly well. But what you can also see is something like this. And so this is the X-ray of a patient. And it looks like the cannula is maybe not quite in far enough, but maybe it is. You don't know. It's kind of hard to say with overinflation of the lungs. But you get the echo, and you see, oh, sure enough, the tip of that cannula is not quite in the IVC. In fact, that little thing that's flopping around there, that's the eustachian valve, and that can get wrapped around the bottom of the cannula and cause all kinds of hemolysis. But also it creates a huge amount of inefficiency of recirculation. And the other problem with that eustachian valve, you can see it it's the green part of it here. It's really big in babies, and it gets much smaller in adults, or maybe we just outgrow our eustachian valve. But it becomes a problem because for these dual lumen cannula, if they're not properly seated, and the patient's moving around, really aggressive respiratory therapy, that cannula can pull up into the atrium, and I guarantee you it will never go back down in the IVC. It will always go to the other side of the eustachian valve, and it could eventually potentially erode through. So really good placement, confirmed by echo, is the way to go. So this is another potential problem. This is someone where the cannula was placed maybe a little too aggressively in too far. Obviously, they didn't use echo to confirm this thing. And you can see the return ports way down in the abdomen. So this is just a horrible problem. This is massive recirculation, and it's just not going to be good ECMO. So that needs to be adjusted. Without using proper guide wire technique, I think, I forgot who mentioned it yesterday. It may have been Bob. Mentioned that Seldinger was, such an amazing person. I mean, he was. Seldinger has basically kept almost all of our patients alive. He and Netter, I would suppose. But without proper wire technique and visualization, it's very easy for that cannula to go in the wrong place. And it can also go into the ventricle, and I've certainly seen this as well, and it can erode right through the wall of the right ventricle. So again, this can all be prevented by good confirmation and good technique to begin with. Here's another couple of embarrassing examples of cannula that have gone in the wrong places. Again, thank God they were caught at this stage. Now this is a uniquely bad one. This is you can look at this X-ray on the X-ray, and you can see this is a kind of a funny curve to the cannula. And I don't know why, but it seems like in ECMO anyway, there's always 5 places that a cannula can be, and only one of them is the good place. And so in this particular, one of the 5 happens to be the pericardium. And so you can see on that echo, there's this massive pericardial effusion. And, it's unfortunate, but it's pretty impressive, actually. The patient's still alive with this because we actually have a functioning echo. So we were able to fix this. But again, this is a terrible complication. The patient easily could have died. It could have been 100% prevented with proper technique and proper confirmation as a cannula is being placed. And here's just an example of, we all know what that looks like. So this is a great slide from Heidi. I personally do not use fluoroscopy for VV ECMO cannulation, but our general surgeons like to use this. And this is why, because you have a nice planar view. You can see the wire going right down the IVC. You can see there's no kinks or anything. I mean, this is a great technique if your patients are well enough to do it and you have the facilities to do this. But again, really critical preparation and confirmation. Let's talk a little bit about the lower extremity. So the lower extremity, just like the neck's got this potential risk up there, the lower extremities have a major risk, and it's usually not in the leg, it's actually in the pelvis. Because if you look at the femoral vessels, they go into the iliacs, they take all these weird turns. They turn from lateral to medial, and then they go from, basically, posterior to anterior. And for each of those turns, this wire has to make that turn, and these rigid, pointed cannulas have to make that turn. So there's great risk. If you want to hear a bad story, talk to Giles Peak. He'll tell you about a patient that he had to split from groin to neck to try to address a problem of cannulation related to this. So the one risk is the actual cannulation site. The other is distal complications. So this is this patient on the right. This is an adult patient who has an ischemic limb, and you can look at it. It's white. These diligent nurses will be pushing it like crazy, trying to get it to blanch. It's never going to blanch because there's no blood in there. That is essentially a surgical emergency, and it has to be addressed immediately. Otherwise, the patient will lose a leg and likely lose their life. So how can this be prevented? Right? This is very easy to occur. Well, it can be prevented by doing different things. You can sew side grafts onto the vessel to provide differential flow, both proximal and distal. You can directly cannulate the vessel in two different directions. I mean, the most important thing is recognizing the risk for it and then addressing it head on. So I would say that more and more programs are preemptively placing a distal reperfusion cannula into the leg to prevent this type of a complication. Certainly we are. And my tip for the group who are doing this percutaneously, is if you're going to put a reperfusion cannula into the leg, the lower leg, or distal leg, put that in first, put the wire in first. Because once you put the patient on ECMO, there's going to be no flow getting down there, and you're never going to find that vessel on ultrasound. So if you're going to do it and you have the time, put the distal perfusion cannula wire in first, then you can cannulate, then you can go over that wire to take care of that. So, I guess in summary, ultrasound is really important for everything we do, that and echo. If you have any problems, get an echo. And, these vessels are incredibly fragile. All neonatal vessels are fragile, and every single adult vein is fragile. And so what you really need is a very gentle touch and really be prepared. Be prepared for complications and be prepared to prevent the complications. Thank you very much.
So, you know what? I think we've got like 5 minutes or so that we can do questions. So I'm going to have the speakers come up here if you can. And if anybody has a question, please come to the mic. Or if you've got a really loud voice, you can scream. There's got to be one question with all these people in the room. So come on.
Hi.
Thank you.
My question is for Dr. Roy. She's still here? Oh, okay. This may be a very niche question, but I've encountered a few patients who have very severe BPFs and who've never really gone on ECMO to manage those. And I was just wondering if you had any advice on how aggressive to be when they are poor surgical candidates to possibly put them on ECMO to help heal that BPF.
Thank you. Thank you for the question. I've managed one patient with a BPF on ECMO, and it was a patient who was incidentally having respiratory failure too, and it was a patient who was post pneumonectomy with a large stum dehiscence, and he was basically rapidly deteriorating. So that was the impetus to manage him that way. It required surgical revision, obviously. I thought it was interesting to see that in the setting of ARDS, some programs manage those patients who are deteriorating with ECMO, and that and that they were able to successfully manage them conservatively in that setting. But that I have not used it primarily. I just thought I would report it as I thought it was interesting.
Yes, sir.
Enrique Bongora, UAB. Philip, great presentation. My question is regarding pulmonary hypertension. On the COVID patients, it seems like these patients are more prone to develop pulmonary hypertension than the regular ARDS patient. At least that's my impression. And have you had any experience with transitioning those patients to VA instead of a Protect Duo cannula or right atrium to PA cannula? Because, you know, those patients tend to take a long time to recover, and sometimes VA may be difficult to be able to get those patients through. Hence, we tend to do the Protect Duo cannula, but we also run sometimes into limitations with flow because it may not give us enough flow to be able to get that patient through. So I just wanted to see what your experience was.
Yeah, I think for a lot of reasons, I'm glad to see COVID start to peter out, and one of them is dealing with RV failure in the middle of the night. So we were actually really lucky with PA support for up to 165 days as a bridge to transplant, and actually 101 and 165 days. But something I didn't say there, we have also done that with a single lumen cannula, like a 19 French long venous cannula placed through the left subclavian or the right IJ into the pulmonary artery, using that as our reinfusion and then a standard femoral drainage. And we probably did that as often as we did Protect Duo. And that configuration gives a lot more flow. It was better in a lot of ways. I will also disclose we did have a pulmonary rupture from that cannulation, and it didn't happen at the time of the procedure. It happened a week later. So it was not a procedural complication. After that happened, I kind of backpedaled a little bit, and we kind of retreated back to the Protect Duo. Whether that's something that was just going to happen or not, I don't really know. Whenever we went on VA ECMO, I don't recall that we ever did it electively. It was always a mess. It was always a dying patient. And so we cannulated him through the groin. And since, as you said, they were always on for so long, we would sustain it for a week or so, but we were always looking for a way to transition to something else. And almost always that was a pulmonary artery cannula. I think in some centers that would have been a subclavian artery ECMO configuration. The surgical group I work with is just not eager to do that, and so we were pretty successful. But I agree with you, the Protect may not give you all the flow you need. There's a group, and I wish I could remember who it was. If somebody's here, I apologize if I'm not recognizing you appropriately. They described a femoral artery drain, like a 25 or 27 French, and then reinfusing through both lumens of the Protect. And so they got much higher flow. Now, not all of it was into the pulmonary artery, but they got a fair amount of PA support, and the rest of that, quote, excess flow was veno-venous support, which seems like a brilliant strategy to me. We didn't have an opportunity to try that, but maybe a way to address that lower flow. Thanks.
Yeah, Randy Fortuna from Loma Linda in Southern California. My question is about managing bleeding with procedures on ECMO. The concept of preparation really rings true. And the question is, when you're going to be putting a chest tube for someone on ECMO, you can hold the anticoagulation but still have bleeding problems. What's your experience with using antifibrinolytics such as Amicar?
Yeah, no, definitely. I think we use TXA at our institution, but that or DDAVP. If the patients have been on ECMO for a long time, you might have some acquired von Willebrand syndrome, and I think that preemptively, you know, if you're able to use point of care to direct your interventions, obviously it's a little bit better. But I think there's low level of complication with using the TXA on ECMO and DDAVP. I think when you're talking about more aggressive forms of reversal, like, you know, factor 7 and things like that, then that becomes, everybody's a little bit more anxious about doing that. But yeah.
Can I ask a question? So you ever reverse? Do you simply reverse what you have? Are you heparinized, or were you?
No, I mean, I've not reversed patients. Usually wait until but sometimes you have to just put the chest tube in right when you have patients.
Well, don't you think one of the things that I think we've become more comfortable with is stopping anticoagulation, especially in bigger patients? I mean, I have a 12-year-old right now. He had a pneumonectomy, and he's been off anticoagulation for a week, and he's got a cannula that's 100 days old, and he still hasn't clotted it off or anything else. So I think we are a little bit more willing to do that maybe than we were in the past, and that doesn't always help either, just stopping the anticoagulation, but certainly that something can be helpful. Yes, please.
I have a question for Dr. Roy about the role of management of parapneumonic effusions, especially after ARDS, septic lesions as such. What strategy would you employ in those situations, especially when you have a patient on ECMO? We did hear about the pneumothorax piece. If you can comment on the pleural effusions and parapneumonic effusions.
I think if you think that the patient is septic and has an effusion that is infected, I think it's important to try to get a diagnosis and potentially treat it. I think image guidance is really the way to go for managing all these either a pneumothorax or an effusion. I think that it's really important for surgeons to or to consult with your radiologist if you're not sure. But I think that these should not be blind procedures. They should be image guided. I think you can transport your patients to the CT scanner if you are concerned prior to then performing a bedside ultrasound if you can. But having a good definition of the the fusion, where it is, if it's loculated, and then proceeding with image guidance and stopping anticoagulation prior if you're able to.
Any comments by the panel on the role of TPA in this situation?
It's a little uncomfortable to use TPA on an ECMO patient. I personally have not done it. I've used TPA in a post-surgical patient who has been bleeding and has required multi-chest tube management with TPA, and that's also sometimes a little uncomfortable. But I've personally not used it on an ECMO patient.
We've had pretty good luck using TPA a handful of times. I always keep this adage in mind when I'm using it. I could always give more, but it's hard to take it back. And so, you can choose one of two things. You can modify your dose, which I do, down, and you can modify your dwell time. You don't have to leave it in for an hour before you drain it. So I always say just start small. I can always do this again. And I think the standard is to do it 4 times a day. No, sir. We do it once, we do a small dose, leave it for 30 minutes, and just see what happens. And we've had pretty good luck. I'll also say about pleural effusions, I work with, I hope none of them are here, I love the guys, but some of the pulmonologists I work with just can't help themselves. When there's a pleural effusion, they feel like they have to drain it. And that's a problem. So the justification is often, well, what if it's infected? And where we meet in the middle and what works really well is I encourage them to do a thoracentesis, a diagnostic, not with that big 8.5-inch harpoon kit, okay? That's an agent of death. But just with a small centesis needle and just under ultrasound guidance, find a nice deep pocket of fluid and take 10 cc's off and do studies on that fluid. More often than not, it's a simple effusion and the conversation is done. If it's infected, now I feel like it's justified taking the risk of a formal tube to drain that. So I find that's a nice middle ground sometimes.
Just speaking about formal tubes, yet I'm a surgeon, but in that population, I prefer by far having PERC tubes placed because they carry the advantage of being snug the exact same size as the dilator, in contrast to a surgical tube where usually, especially if it's a resident, they're going to open the coker like 10 centimeters wide, which is going to disrupt the whole intercostal muscle bundle. And so just having the ability to place a tube, and even if in your center, which we unfortunately don't do, you can have up to 32 French PERC tubes. It's not specifically a small, like pigtail, as can sometimes be placed by IR. It can be a genuine tube with serial dilators. But in the end, what is nice with these is that the tract is the exact same size as the tube, which is sort of going to self-tamponade. It's going to work and it's going to be helpful in some of the patients. Must say that we've had a lot of bleeding complications in the COVID population that seems to have a more intense pleural inflammation than other patients. And in these patients, indeed, we were kind of refraining draining unless we would believe that it would really help the patient. Like If the patient is still completely whited out with a 2 centimeter appearing effusion, no sepsis apparently from behavior of the patient and some degree of an effusion, but like miles away of coming off ECMO, we would just leave it there and just watch and only be a little bit more aggressive if it would make a meaningful change for the patient in terms of general management, but not drain all of them just because there's one. Be more prudent and then perk.
As a pulmonologist, I feel a need to respond to Phil, but unfortunately,
No, I said the people
we're
I
out of
work
time,
with.
so I'm going to refrain. Thank you, everyone, for joining. If you guys have questions, you're probably welcome to come up here, but have a good rest of the day.